Good day, these great surgeons. Today we're gonna talk about the breast and all endocrine pathologies. Very important questions in the exam, and we will remove the confusion together. And it's overlapping with many chapters like pre-operative and post-operative, as well as the anatomy and physiology. This is endocrine. So let's crack up this important chapter together in these voice shots. Hope you like it, and together we can.
Take care. Axillary node clearance is associated with development of lymphedema. You will find the arm of the patient will be very huge after the surgery with months. This increases the risk for cellulitis and frozen shoulder. The majority of small adrenal lesions are incidental, benign, and non-functional adenoma. Away from the minimal workup, no further investigation is needed. Of note, if there is concern about malignancy, the only surgical option is adrenalectomy. So, adrenal gland, no biopsy is needed. Just go with adrenalectomy as long as malignancy is suspected. Take care. In adrenal gland malignancy, any mass in the adrenal gland above 4 cm, 25% of them will be malignant. So it should be excised and done adrenalectomy. There is no biopsy in adrenal gland enlargement. Such lesion should usually be excised. Lesion is suspected metastatic deposit. A biopsy may be considered if there is a metastatic deposit. Familial hypocalciuric hypercalcemia. Hypocalciuric means calcium is low in urine. Hypercalcemia means calcium is high in the blood. So familial hypocalciuric hypercalcemia, FHH, is an inherited disorder that causes abnormally high level calcium in blood, hypercalcemia, and low to moderate level of calcium in urine. And people with FHH usually don't have any symptom and are often diagnosed by chance during routine blood workup. Although some primary lesions are small enough for breast conservative surgery, the presence of axillary lymph node metastasis will attract recommendation for axillary node clearance. You can consider mastectomy, breast mastectomy, for a multifocal tumor, central tumor, large lesion in a small breast, and that carcinoma in situ more than 4 cm, and according to the doctor-patient choice. If we are searching for the single most important prognostic factor in breast cancer, it will be the nodal status. The nodal status, the lymph node metastasis status, is the important because it serves as a marker for tumor metastasis potential. This translates the survival advantage up to 40% to 5 years. Both grade and size are of secondary importance, as they pose less concerning in the absence of nodal involvement. With long-standing, very large goiter, there is a risk for tracheomalacia. Tracheomalacia is a condition or incident where the cartilage that keeps the airway, which is the trachea, open and soft, such that the trachea partially collapses, especially during increased airflow. The usual symptom is a stridor when a person breathes out. This is usually known as collapsed windpipe. Acquired tracheomalacia is severely symptomatic and can be treated with internal stenting or external stenting, or even tracheostomy. The use of various type tube or stent for the management of tracheomalacia is very helpful. Thyroid lymphoma. It's a non-Hodgkin beta cell lymphoma, which is rare by the way. It should be considered in a patient with a background of Hashimoto thyroiditis and rapid growth inside of the thyroid gland. Diagnosis can be made with core-needed biopsy. However, an incisional biopsy may be needed. Radiotherapy is the main stage of treatment option for thyroid lymphoma. Hashimoto thyroiditis. It's an immunological disorder autoimmune disease in which lymphocytes become sensitized to thyroidal antigen. The three most important antibodies include thyroglobulin, TPO, and TSHR. During the early phase of Hashimoto, the thyroglobulin antibody is markedly elevated and then declines. The features of Hashimoto thyroiditis: it will have a goiter and either euthyroid or mild hypothyroid. Take care. Again, it's a goiter with euthyroid, normal thyroid function, or mild hypothyroidism, and will cause progressive hypothyroidism and associated with symptoms of hypothyroidism. The management of Hashimoto thyroiditis: usually the hyperthyroid phase of illness with beta blocker may manage the symptom, but when we come to hypothyroidism, it will require thyroxine. Care: Hashimoto thyroiditis may complicate to beta cell lymphoma, non-Hodgkin type of lymphoma. For short, remember that lymphoma is Hodgkin and non-Hodgkin. For simple, non-Hodgkin is not good. Hodgkin is good. We'll talk about it in details later on. Elevated T4 and low TSH indicates thyrotoxicosis. Remember, AF and complication like acute ischemia of the limb can be precipitated by hyperthyroid disorder. And take care, in primary hypothyroidism, primary atrophic hypothyroidism, you will find that T4 is low and the TSH is high. Simply, the T4 is secreted by the thyroid. So if the thyroid is hyperfunctioning, it will be secreting T4. And if hypofunctioning, it will not secrete T4. And the TSH is secreted by the pituitary gland. So, if the pituitary is secreting high TSH and the thyroid doesn't secrete T4, so the problem in the thyroid and it's a primary hypothyroidism. But if the TSH is low and the thyroid doesn't secrete T4, so the pituitary gland is responsible for this hypothyroid status, and this is called secondary hypothyroidism. Take care. For the hospitalized patient and long-term bedridden patient with long comorbidities, you might find him with a syndrome called sick euthyroid syndrome, where the TSH and T4 is low for nothing because he is chronic ill, with chronic illness. In thyrotoxicosis, we have two main topics, the primary and the secondary. The primary is gravis, the secondary is secondary thyrotoxicosis, nodular type, plumber disease. Primary thyrotoxicosis can be managed medically for 1.5 years or 2 years maximum, waiting for remission. If the patient was treated with the carbamazole and beta blockers medications and became good and well, there is no surgery for primary hypothyroidism. For the secondary hyperthyroidism, plumber's disease, the mainstay will be thyroidectomy after being euthyroid. So we are preparing the patient to be euthyroid for the operation, not waiting for remission in secondary type of thyrotoxicosis. A very important clinical sign to differentiate between the primary and secondary hyperthyroidism is the eye sign. In Graves' disease, the primary hyperthyroidism, you will find positive eye signs, which is not present in the secondary hyperthyroidism. And in the primary hyperthyroidism, it will be diffuse with no nodule. When you put your hand and palpate it, you will find it diffuse. There is no nodules. But for the secondary hyperthyroidism, you will find it nodular type. Great. The commonest site for metastatic breast cancer is to pony site, often the axial skeleton, the lumbar spine. And so, hypercalcemia is often present in those with metastatic disease who are acutely unwell. So, when you find hypercalcemia in a patient, the main causes of hypercalcemia might be malignant or primary hyperparathyroidism. Malignancy, most common cause in hospital inpatient, and the primary hyperthyroidism, commonest cause in non-hospitalized patient. Less common cause for hypercalcemia, keep in mind, sarcoidosis, cystitis, and immobilization or baggy disease, vitamin A or D toxicity, thyrotoxicosis, MEN syndrome, and milk alkali syndrome. Just keep those in mind. Milk alkali syndrome is frequently asked in the exam as a cause for hypercalcemia, as well as cystitis and malignancy. Hypercalcemia is clinical features will be presence of stone, mood, GIT, bone, mood, stone, GIT, bone, mood, stone, and GIT. You will find mood changes, psychic moans, and stone formation all over the body. You will find the stone formed in the gallbladder and the urinary bladder, and whole urinary tract stones, wherever stone can be formed, even in the salivary glands. So think of hypercalcemia causes and bone aches as well as abdominal pain. So bone, mood, stone, GIT indicated for hypercalcemia, and you have to think for the causes. Again, sick euthyroid syndrome is caused by systemic illness. There is nothing wrong with the thyroid gland. With this, the patient may have apparently low T4 and T3 with normal or low TSH. Again, T4 and T3, as long as the TSH will be apparently low due to systemic illness. There is nothing wrong with the thyroid. In thyroid cystic lesion, the risk of malignancy of pure cystic lesion are very low, and that's why the surgeon offer aspiration as well as sclerosing injection. The sclerosing injection, like ethanol, have good result and avoid the resection and the hazard of the operation. If less than 4 cm nodule suspected for malignancy in thyroid, go for hemithyroidectomy. Like the papillary, if less than 4 cm, go for hemithyroidectomy. If more than 4, go with total thyroidectomy. In hypercalcemia, the first thing to do, whatever is the cause, is administration of IV crystalloids. Lymphedema is due to impaired lymphatic drainage in presence of normal capillary function. Lymphedema causes the accumulation of protein-rich fluid, subdermal fibrosis, and dermal thickening. Characteristically, fluid is confined to the epiphyseal space, skin and subcutaneous tissue, and muscle compartment are free of the edema. It involves the foot, unlike other forms of edema. There may be buffalo hump or dorsum of the foot, and the skin cannot be punctured due to subcutaneous fibrosis. Again, it will be confined to epiphyseal space like skin, subcutaneous tissue. Muscle compartment will be free of edema, and it will involve the foot, unlike other forms of edema. Causes of lymphedema are either primary or secondary. Primary called Medullary disease or MEG disease. Medullary is congenital below 1 year old, and the secondary will be bacterial, fungal, parasitic, or even surgical, radiotherapy, DVT, thrombophlebitis. All of those may cause secondary cause of lymphedema. For your own knowledge, the super microsurgery now is a hope for lymphedema, either the primary or the secondary types. The primary types of lymphedema, less than 1 year, will be Medullary. If onset between 1 to 35 years, is sporadic MEG disease, and if more than 35 years, lymphedema tarda, primary causes. So just know that Medullary, MEG, and lymphedema tarda are primary causes. When to do surgery for lymphedema? when there is a marked disability or deformity from lymph swelling, lymphedema caused by proximal lymphatic obstruction with patent distal lymphatic suitable for lymphatic drainage, or lymphocutaneous fistula or megalolymphatics. Those are the indications for the surgery. According to the MRCS, you have either Homan operation or Charles operation or lymphovenous anastomosis. And by the way, lymphovenous anastomosis is the coming hope for lymphedema, but it requires super microsurgery and high qualified training. According to the MRCS, the lymphovenous anastomosis is usually indicated on only 2% of the patient with proximal lymphatic obstruction, unlike the promise we are talking about as a promise for the lymphedema patient, because most of the operation for the lymphedema patient are not hopeful, except for this super microsurgery. But MRCS consider it not a hope at all and indicated for only 2% of the patient. The longest standing lymphedema may cause lymphangiosarcoma. It's a rare condition arising as a result of chronic edema. It's aggressive malignancy. Homan's operation as a management for lymphedema, if indicated, it's a reduction procedure with preservation of the overlying skin, which must be in a good condition, by the way. If you are going to preserve the skin, it must be in a good condition. Skin flaps are raised and the underlying tissue is excised and lymph circumference typically reduced by a third. Charles operation. All the skin and subcutaneous tissue around the cuff are excised. You literally deglove the lymph. All the skin and subcutaneous tissue around the cuff are excised down to the deep fascia. And you have to do split thickness skin graft to cover this raw area. It may be performed if overlying skin is not good condition and larger reduction size than Homan procedure. Water-Friedreich syndrome is defined as adrenal gland failure due to bleeding into the adrenal gland. It's caused by severe bacterial infection, most commonly the meningococcal Neisseria meningitis. In Water-Friedreich syndrome, the bacterial infection leads to massive hemorrhage into one or usually both adrenal glands, characterized by overwhelming bacterial infection, meningococcemia, leading to massive blood invasion, organ failure, coma, and hemodynamic shock. Disseminated intravascular coagulopathy, which is TIC, with widespread purpura. It will go with rapid developed adrenocortical insufficiency and eventually death. Tamoxifen is estrogen receptor antagonist in breast tissue. However, in other sites such as endometrium, it may act as an agonist. That's the reason it might increase the endometrial cancer in the same way it used to treat the breast cancer. So, tamoxifen is synthetic partial estrogen agonist, active primarily by binding to estrogen receptor. Its half-life is 7 days, takes 4 weeks for drug to reach plasma steady state. Should usually be considered in patients with estrogen receptor positive tumor. Estrogen receptor positive tumor, tamoxifen. Although it has antagonistic effect respected to the breast tissue, tamoxifen serve agonist in other sites like endometrial cancer. Endometrial cancer is increased by tamoxifen. It has climatic side effect. 3% stop taking the drug because of the climatic side effect. For the recurrence assessment in follicular carcinoma of the thyroid, you should use serum thyroglobulin. Hashimoto thyroiditis usually present in women aged between 30 to 50 years, and they are normally associated with goiter. There is a thyroid enlargement, but take care to differentiate it from hypothyroidism. The antithyroid peroxidase antibody will be elevated in Hashimoto thyroiditis. In every lactating mother, whenever a tender breast lump is felt in a lactating mother, consider it breast abscess and never wait for fluctuation until proven otherwise. And by the way, in a lactating mother, whenever you drain an abscess and it's resistant to treatment, consider it mastitis carcinomatosis and never miss it from your differential. Take care. Development of jaundice in people with thyrotoxic storm is well described and etiology is multifactorial. So never be confused when you find jaundice in patient with thyrotoxic storm. And the first instant to control the cardiac rate and administration of antithyroid drug is usually the typical used in thyrotoxic storm. So use beta blocker and thionamides along to treat the thyrotoxic storm, and it's a very common recall question. Take care. Hypoparathyroidism is a recognized complication following thyroid surgery, and damage to blood supply to the parathyroid gland is probably the commonest cause. The incidence of permanent hypoparathyroidism in about 1 to 3%. It can present dramatically in the first 2 to 5 post-operative days. In the emergency setting, treatment if the intravenous calcium gluconate or calcium carbonate is used in long term. Identifying of the thoracic duct, you should administrate high-fat meal 3 hours before the surgery with urozyte dye, and before the incision up to 1 liter or more heavy cream meal administered intrally. And to identify the parathyroid intraoperatively, you inject methylene blue. Remember, trastuzumab is used to target the HER2 receptor in breast cancer. Trastuzumab is Herceptin and Herceptin is trastuzumab. Both are the same thing used for targeting the HER2 receptors in breast cancer. Combination of nipple discharge, Genicomacia, poor vision is associated with prolactinoma. Not just prolactinemia, it's prolactinoma. There's a tumor causing Genicomacia as long as poor vision and nipple discharge. It's due to the compression of the optic chiasm resulting to bitemporal hemianopia. In hyperthyroidism, the signs and symptoms are like a very aggressive female in her PMS. Just think of it if you forgot it. The symptoms will be lethargy, emotionally labile, and heat intolerance, and weight loss, excessive appetite, and palpitation. And the signs will be tachycardia, agitation, hot moist palm and exophthalmos, thyroid goiter and pruee, and lead leg retractions. Just a female in her PMS. Combination of grade 3 tumor and axillary nodal metastasis in young female would recommend chemotherapy, and you can add Herceptin if she had HER2 positive. The causes of Genicomacia are medical and drugs. So the drugs are in mnemonic called Disco, digitalis, isoniazid, spironolactone, cimetidine, and estrogen. Disco, where estrogen starts with an O. The general medical causes for Genicomacia in a mnemonic called metoclopramide. The metoclopramide itself is a drug that causes Genicomacia, and every letter in the word metoclopramide is a mnemonic for the causes of Genicomacia, from metoclopramide, ectopic estrogen, trauma to the skull or tumor to the breast or the testis, orchitis, cimetidine or Cushing, liver cirrhosis, obesity, paraplegia, RA or acromegaly, methyldopa, isoniazid, digoxin, and ethonamide. By the way, Genicomacia is abnormal amount of breast tissue in male and is usually caused by increased estrogen to androgen ratio. The estrogen would be more than androgen. It's important to differentiate the cause of galactorrhea due to the action of prolactin on the breast from those of Genicomacia. Ductictasia. As women progress through menopause, the breast duct shortens and dilates. In some women, it may cause a cheese-like nipple discharge and slit-like retraction of the nipple. There is no specific treatment is required, however, it might require Hatfield operation. Smoking is a major risk factor for ductictasia, by the way. Regarding breast investigations, take care from the word investigation for a lump, screening for breast cancer, investigation for a breast lump, or screening for breast cancer, and whether you are investigating for the implant problem or the breast lump. To screen the breast, we use imaging for breast screening, unless there is a strong family history for cancer. We will use MRI regarding screening. For investigating breast lump, the young female, you will use ultrasound. The old female, you will use imaging. This is regarding the breast lump. When you are investigating the breast lump, just follow the age group. The young age with ultrasound, the old age with imaging. Yes. And if we have an implant, you take care. You are not investigating for the implant problem. You are investigating for the breast lump. The breast implant is investigated if he has a problem with MRI. But the breast lump, whether there is an implant or not, just follow the rule. The young age with ultrasound, the old age with, yes, imaging. In breast investigation, core biopsy versus fine needle aspiration cytology. The core biopsy is preferred over fine needle aspiration cytology by most surgeons, because the reason for this is that fine needle often yielded inadequate tissue for assessment. When fine needle demonstrated benign changes, it had to be repeated at least once to confirm this. If it yielded that were intermediate, then a core biopsy was needed. So a core biopsy removes many of the stages and just to the point. Regarding thyroid malignancy, Medullary carcinoma is the commonest subtype of thyroid malignancy, and it can be accurately diagnosed by fine needle aspiration cytology. Histologically, they may demonstrate samoma bodies, which are areas of calcification, and so-called orphan any-eyes nuclei, and frequently asked in the exam, the orphan any-eye nuclei. They typically metastasize via lymphatic and thus laterally located. Apparently, ectopic thyroid tissue is usually metastasized from a well-differentiated papillary carcinoma. So, common subtype can be diagnosed by needle, histologically show samoma body and orphan any eyes. They typically metastasize lymphatic route. Follicular carcinoma of the thyroid, less common than papillary. They tend to use the blood route of metastasis, hematogenous spread metastasis. They translate to high mortality due to the hematological spread. The follicular lesion can't be accurately diagnosed by fine needle aspiration cytology, and thus the follicular will require at least hemothyroidectomy, if not total thyroidectomy. Again, the hemothyroidectomy for lesion below 4 cm, if more than 4 cm, you will do total thyroidectomy according to the NHS rules. The anablastic carcinoma, less common and tend to occur in elder female. The disease is usually advanced, often only palliative decompression and radiotherapy can be offered for the anaplastic carcinoma. Be attention regarding medullary carcinoma. Medullary carcinoma are parafollicular C cells of neural crest origin. The serum calcitonin is a tumor marker of the medullary carcinoma. Yes, the serum calcitonin is a tumor marker for the medullary carcinoma because it will be elevated and is a good monitor for recurrence. So thyroglobulin is good for monitoring the recurrence of papillary or follicular, but regarding the medullary carcinoma, the calcitonin is the tumor marker of choice for the carcinoma itself, the medullary carcinoma, and to detect the recurrence. Of course, medullary carcinoma is very famous for its familiar origin and association with MEN2A disease spectrum. Spread may be either lymphatic or hematogenous, both, and thus tumor are not derived primarily from the thyroid cell. They are not responsive to radioiodine. So, medullary carcinoma, familial, parafollicular C cell, calcitonin high, and its tumor marker associated with MEN2A disease spectrum. Remember that the radioiodine can worsen the eye signs in Graves' disease. So, radioiodine is not wise to be a choice in the Graves' disease. So, for the management of Graves' disease of the thyroid, mainly medical, using carbamazole. In non-pregnant, in pregnant you use propyl thyroxine. Both ways will be covered under the umbrella of beta blocker. And you have to differentiate between Graves' disease with significant eye sign. So you will do total thyroidectomy if failed to do remission and failed to respond to the medical trial. And if Graves without significant eye sign and failed to do remission and failed to respond to medical response, so patient choice will be radioiodine and surgery. Radioiodine is medical thyroidectomy, by the way. So, Graves' disease mainstay is medical. If you choose that he didn't respond to medication, you either do total thyroidectomy if he have eye signs, or you can choose between radioiodine or surgery if he doesn't have eye signs. By the way, radioiodine is preferred in old patient, not the young age. Regarding the blood testing in thyroid disease, thyroid peroxidase, the microsomal antibodies, are found in autoimmune disease affecting the thyroid like Hashimoto and Graves' disease. Again, thyroid peroxidase found in autoimmune disease affecting the thyroid like the Hashimoto and the Graves' disease. Hashimoto 100% will have thyroid peroxidase. Graves 70% will have thyroid peroxidase. So now you are familiar that Graves' disease have two antibodies. The antibody to TSH receptor and the thyroid peroxidase, the microsomal antibodies. And never forget that thyroglobulin not useful for clinical distinction between different types of thyroid disease, but used as a follow-up for thyroid cancer follow-up. If you are suspecting recurrence of thyroid malignancy, use thyroglobulin. Hope it's clear now. Of course, you all know that the most common cause of bleeding per nipple is duct papilloma. However, you have to exclude the duct carcinoma in situ. That's why any breast lump or any breast discharge should be treated and managed with the triple survey. Okay? Triple assessment or triple survey. Triple assessment for the breast. According to the NHS, it includes 3 modalities. From its name, triple, 3. Physical examination and history. Imaging, either mammography or ultrasound. Biopsy, either FNAC or core biopsy. Triple assessment of the breast. A solitary thyroid nodule with signs of hematogenous spread. Of course, follicular tumor. Note that papillary tumor tend to be multinodular and spread via lymphatic system. And the lymphatic spread from the papillary thyroid carcinoma cancer is nearly always to the neck lymph node in the first incidence. And mediastinal lymphadenopathy is very rare. Lung lesions are typically for hematogenous metastasis. The mnemonic for hematogenous spread is lip-lip, lung, brain, bone, and liver. The adrenal lesion may be found accidentally in CT or during surgery. If the size below 3, homogeneous texture, lipid-rich tissue, and thin wall, there is no way to worry. You have only to worry if the lesion is functioning or the size above 3 centimeters. Let's remember that pheochromocytoma is neuroendocrine tumor of chromaffin cell of the adrenal medulla. Again, pheochromocytoma is neuroendocrine tumor of chromaffin cell of the adrenal medulla. Hypertension and hyperglycemia are often found. In 10% of the cases, it will be bilateral. So this means it's common to be unilateral. In 10% of the cases, it will be in children. So it means it more often in adults. In 10%, it will be malignant. So pheochromocytoma is more common to be benign. In 10% of the patient, it will be not hypertensive. So this means it's more common to be hypertensive, hyperglycemic patient. Pheochromocytoma, rule of tens, to satisfy you that the patient will be with good prognosis mostly. And by the way, you have to treat pheochromocytoma in the men syndrome, in the multiple endocrine neoplasia. Deal with the pheochromocytoma first. The diagnosis of pheochromocytoma is made by the urine analysis of vinyl mandelic acid. Okay? And take care, the vanilla make false result, the ice cream vanilla make false result positive for pheochromocytoma. If you know a patient eating ice cream vanilla, you may mock him and make him do the vinyl mandelic acid, and you will find him positive for pheochromocytoma. And you say, ha ha ha. It's false positive for pheochromocytoma. So, to diagnose pheochromocytoma, vinyl mandelic acid, and make sure that the patient is not eating vanilla ice cream, and blood test for plasma metanephrine level, CT and MRI scanning are both used to localize the lesion of pheochromocytoma. And remember, it compromises the rule of tens, and the patient will be hypertensive and hyperglycemic. A very famous question about the indication of surgery for primary hyperparathyroidism. The indication of surgery for hyperparathyroidism, if elevated serum calcium above 1 mg per deciliter or above normal, or hypercalciuria above 400 mg per day, creatinine clearance less than 30% compared with normal, episodes of life-threatening hypercalcemia, nephrolysis, and age below 50 years, or neuromuscular symptoms, and reduction in bone mineral density of the femoral neck and lumbar spine, or distal radius of more than 2.5 standard deviation below the peak bone mass. So again, indication of surgery, elevated serum calcium, hypercalciuria, creatinine clearance is high, creatinine clearance is below 30% compared with normal, and episodes of life-threatening hypercalcemia, nephrolysis, age below 50, neuromuscular symptom, and reduction of bone mineral density. Take care for secondary hyperparathyroidism. What are the indications of surgery in secondary hyperparathyroidism, which is of renal incidence, of renal cause? Of course, you know that hyperparathyroidism secondary type is due to renal hyperparathyroidism. So, the indication of surgery in secondary hyperparathyroidism: bone pain, persistent pruritus, and soft tissue calcifications. Take care of seroma is very common after breast surgery. The exposed raw surface area created during elevation of the skin flap are common cause for creating the seroma. Treatment usually involves percutaneous drainage under a septic condition. Let's compare between the effect of radioiodine, the medical thyroidectomy, and surgical thyroidectomy. Surgical thyroidectomy symptoms improvement within 10 days. No effect on ophthalmology, and risk to damage adjacent anatomical structure would be high because it's surgery invasive, but there is no restriction on contact. Let's now take the radioiodine as a choice for medical thyroidectomy instead of surgery and see the pros and cons. The symptomatic improvement will take up to 2 months. The eye sign may worsen, so take care. And no risk of anatomical damage because it's not surgery. There is no contact with children for 4 weeks. You will have to be away from children for 4 weeks at least. Those were the pros and cons for radioiodine, and that's why it's prepared in old patient rather than younger patient. The pedicle latissimus dorsi flap is a common method for providing breast reconstruction over an implant, and the free flap requires expertise and doesn't heal reliably as the pedicle one, because you have to create the nourishment vessel for the free flap, while the pedicle flap, it comes with its feeding blood vessel. However, in practice, some prefer the diap flap, the free flap of the diap rather than the latissimus dorsi. But let's stick to the EMRCS and MRCS guidelines and rules. So, pedicle latissimus dorsi flap, more common method for breast reconstruction over the implant. Remember, from the subtypes of the follicular thyroid carcinoma is the Herschel cell type, which has a very worse prognosis, very bad worse prognosis, the Herschel cell type of follicular thyroid cancer. Take care. After breast conservative surgeries, radiotherapy is routine. Without irradiation, the local recurrence rate approximately about 40%. These rates are potentially lower in older patients who receive endocrine therapy and who have small low-grade tumors. Take care, it's due to hypocalcemia from parathyroidectomy during thyroidectomy. So take care, it's due to hypocalcemia. We only remove the sutures if you are suspecting a hematoma formation, which will cause a swelling, or seroma formation, which will cause oozing from the wound, guys. Intraoperative if you are suspecting removal of the parathyroid gland, either intentionally or accidentally with the thyroid gland total thyroidectomy. You will find that methylene blue would be helpful in parathyroid removal, but if you don't have injection of methylene blue during parathyroidectomy, you can take the gland you have excised, the golden yellow color specific for parathyroid. If you are not familiar with it, and mix it with the fat of the neck, take this fat and put it in the saline or the water. If you find that the parathyroid drops down to the water, it's a parathyroid gland. But if this golden yellow floats over the water, it's probably fat and not the parathyroid. And the clinical wise, if you take a parathyroid hormone test intraoperative, you will find it drop within 10 minutes, because the parathyroid hormone has a very short half-life, usually less than 10 minutes. Therefore, the drop in parathyroid hormone will be in 10 minutes from its removal. If you take a sample and test the patient after 10 minutes of the removal and suspected parathyroid gland removal, you will find that the parathyroid hormone is not in the body anymore. Combination of established axillary disease and multifocal invasive lesion attracts an indication for mastectomy and axillary clearance. By the way, a radical mastectomy is less frequently indicated in modern surgical practice, because disease that is locally advanced is often best downstaged using medical therapy rather than embarking an operation for a breast cancer that were first popularized over 100 years ago. As a rule, multifocal breast cancer is best treated with mastectomy. Wide local excision is the surgery of choice for solitary lesion, peripheral tumor, small lesion in large breast, or duct carcinoma in situ less than 4 cm, and according to the patient doctor choice. Take care. Central lesions may be managed using breast conservative surgery, where an acceptable cosmetic result may be obtained. But this is rarely the case in small breast.